Hello, good afternoon. Thank you for joining us for this month's QTECH committee meeting. We're going to get started in just a few minutes. So please enjoy our marketing slide deck. We do have an around the virtual room question that we'd like everyone to prepare to unmute their lines to share. And it's all around the plan. So what is your health center's plan for administering the third or booster COVID-19 vaccine? So any sort of patient engagement campaigns that your health center may be thinking through or workflow adjustments, or even thinking through some extended hours or weekend events. So those are just some things to get your mind going for the around the virtual room. So we will get started in just a few more minutes. Hello, good afternoon. Thank you for joining us for this afternoon's QTECH committee meeting for the month of August. We're going to get started in just a few more minutes. Hello, good afternoon. Thank you for joining us for this month's QTECH committee meeting. We're going to get started in just about 2 more minutes or so. On the screen, you are seeing the around the virtual room question for today's session. So we're going to be asking for you to be prepared to unmute and share. What is your health center's plan for administering the third or booster COVID-19 vaccine? So any sort of patient engagement campaigns, any sort of workflow adjustments, extended hours, weekend events. So we look forward to hearing from you. I'm going to go ahead and pause the screen so that we can transition to the next slide. Hello, everyone. Good afternoon. We are exactly 5 minutes after the top of the hour, so I'm going to go ahead and get started with everyone today. So thank you for joining us for this month's QTECH committee meeting. On the next slide, we're just going to take a look at some quick webinar logistics. So you have joined this session in a listen-only mode and are muted by default. But to participate in the interactive Q&A via the audio for the telephone, you will need to make sure that you have entered your PIN number for the phone number. You can also use the questions panel during the webinar if you want to share any questions that you might have for our presenters today. And then, of course, this session will be recorded for you to revisit after the session. So thank you again for participating. On the next slide, this is just another quick reference to our QTECH committee goals on the left-hand side. And then, of course, on the right-hand side, we have all the amazing health centers that participate in the QTECH committee. So thank you for joining us today. On the next slide now, we're looking at the agenda for this afternoon session. So we're going to start out first with our welcome and around the room, which we'll be seeing shortly. After that, we're going to transition to our special guest from Commonwealth Health, who's going to be providing their spotlight on a colorectal cancer screening patient engagement campaign that they initiated. After their presentation, then I'm going to pass the floor to my colleague, Fred Ira, who's going to take a look at PCMH 2022, a look ahead. He'll then review some of the 2021 UDS dashboards and comparing that to the 2020 UDS national average that was published by HRSA. And then we'll wrap up today's session with some quick announcements and wrap up. Perfect. So as I mentioned, we are trying to do a virtual round the room question that is about the plan that your health center may have for administering the third or booster COVID-19 vaccine. So we're going to go ahead and look at the chat box, make sure that we're able to unmute everyone's line so that you could share what your health center's plan is for administering the third or booster COVID-19 vaccine. Your line should be now unmuted. If anyone would like to go ahead and take a chance at answering the question we have for the virtual round the room today.
I don't see anything in the chat yet, and folks are unmuted.
Hi, this is Vicki from Treasure Coast Community Health. We are taking care of the vaccines for folks who have the organ transplants and or severely immunocompromised, just integrating them into our well patient visits, which are primarily early in the day now and the sick people in the afternoon. And honestly, we're all praying that something different happens before we have to start the round of third shots for the huge number of people that were immunized in January and February that will be eligible September 20th. Because right now we do have some staff affected.
Thank you for sharing that, Vicki. We really appreciate that. Would anyone else like to go ahead and unmute their line to share?
This is Allison from Commonwealth, and so we're kind of similar. We've had a big decrease in the number of people that are wanting to just get the vaccine, whereas to begin with, we could do 200 people and you know, like have a big event. So we have made sure we've kind of changed that pattern out, and the way to get the third dose in is one, we'll just open it to the public and have certain times. And put that on our social media. But then I think the other thing that we may do is do a campaign to those. We'll probably start with our HIV department is what we've talked about first. We're really talking about getting that group first and then move on to the next group and just trying to see what the request is from the public. But we are seeing the cases increase, and so we're definitely seeing the test and mass testing increasing, and as the test, we feel like that's going to drive in the desire for the vaccine.
Fantastic. Thank you for sharing that, Allison. Great insight. Would anyone else like to unmute and share?
Hi, this is Allison from CHI. Currently, we're administering the third dose to those that are immunocompromised, as well as those who fall into that particular category that the CDC says should have a third dose. We haven't gotten into the boosters yet, as it has not yet been recommended. We are initiating both advertising campaigns as well as administering it at each of our sites. Workflow adjustments, patient engagement, as well as our pop-up weekend and during the day extended hours.
That's fantastic. Thank you for sharing that, Allison. And that's correct. The third dose right now is for those immunocompromised and the criteria from the CDC. And the booster recommendation hasn't officially been sent out yet, but it seems that by September 20th, they may be announcing an official recommendation because CDC and other folks are coming together to talk through that. Would anyone else like to share what their health center has plans for in terms of the third shot and considering the potential of the booster? Go ahead
You
and share
do
that
have
chat.
some items in the chat. Amanda
Oh, I do
says,
see it.
yeah, that they are working with local health department to do clinics. We're also doing vaccines in the clinics daily. We have a recall system from our state registry so that we can contact patients to notify of the need for their booster. And that was from Amanda Drescher, and she's saying that third dose they're currently doing in the clinic.
Fantastic. Thank you for sharing that, Amanda. I do see some other folks who have chimed in the chat as well, where they're sharing. I see from Caitlin Haggerty as well, they're working on a plan. That's fantastic that you've created that preliminary registry and you're working through that process at your health center. That's fantastic. Thank you all for sharing. We do ask this question too because we're in the works of trying to get another COVID webinar session up and running that can speak to some of these. So we're really excited to find out more information from you all in terms of plans and sharing that across the board. Fantastic. Any other folks who'd like to either put within the chat to share or share verbally?
I think we're all clear, Steph. I haven't seen anything else come in.
Okay, fantastic. Well, thank you all so much for taking the time to talk a little bit about what your plans are and trying to get a plan in place potentially for the booster. So we really appreciate you sharing that information. Right now, I'm actually going to pass the floor to our special guest, Allison Hargrove from Commonwealth Health, who's going to talk about a recent colorectal cancer screening patient engagement campaign that they've had at their health center. So Allison, the floor is yours.
Okay. Hi, everybody. So we really worked, we were blessed with some students from Campbell University this past fall. And so one of the things that we wanted to do was focus on this measure. It's one of the harder ones. I think it's based on, we have a very high uninsured population. And so we tried to get creative and see how we had a little, very small amount of grant money from the American Cancer Society, so we were able to use some of that. Can you advance the slide? Okay. So one of the things that we always do with our measures is try to make sure that we define it and make sure that our staff, our doctors, our nurses, the care management team, that they understand what choices that we have and we can offer. So we just clearly define the measure. And one of the things we added last year was the Cologuard with exact science. So it took us a little bit of time to get that in to the system so that when the results come back in, training all 16 sites to make sure everybody knew how to do it. So just defining the measure. And if you'll advance to the next slide. We also updated the stand-in order. So this way, anytime the patient comes into the clinic and the nurse sees the care gaps, the health reminder open, we wanted to make sure that we had a method for them to go ahead and drop the order with the provider during the visit for either the fit test, the colonoscopy, or for the Cologuard. So that was critical. We updated that to add the Cologuard, like you can see, back in November. Advance. So we wanted to make sure that the biggest things that they were worried about our providers were with our indigent population is making sure that we understood kind of which we offer everything to everybody, but understanding if cost is a barrier, that we made sure they were all trained. So the Cologuard representative went to the site, and we made sure they knew that Medicare and Medicaid did cover it with no copay. And it was a test that lasts for 3 years. If you'll advance to the next slide. This was the big thing this Campbell student helped with. So back in October, we had them help design a flyer, and then we had it converted and printed in English and Spanish, and we mailed that flyer out. It took about a month to get them out. We had over, I think, close to 3,000 that we mailed out to the patients, and we wanted we made sure that the providers had this slide, the same thing laminated, so that in their exam rooms that it was kind of out there for the patients to see and ask questions about. So we had a very good response, and the patients would call into we just recently had a new care management department, so that phone number here rang all of their lines. So that gave a way for when they picked up, that care management person tried to facilitate getting the order for that to help the patient, and tried to work on a couple of other closing other care gaps at the same time. If you'll advance the slide. The other thing we wanted to do is, as we sent more out with this measure, the hardest part we see is that when that result comes back, if it is a Cologuard, we didn't have the interface with or if it's a sigmoidoscopy or a colonoscopy, that record, to get credit, it had to be keyed into that HCN quality measures tab. So what we did is we trained our medical record staff how to go in when they saw that. So they would open the encounter in the ordering provider's name, and they would go ahead and drop the F code, and at the same time they would task the provider the result, so the provider could see the report, go look at the report, and then sign off on that F code, so that HEDIS code would be dropped, and so that they would go ahead and review it. We did train them how to do the health reminders, but one of the things that we found, with this measure, since you have to satisfy all 3 health reminders, if you give colonoscopy, you have to satisfy the FIT or the other 2 reminders. What we found is if it was a colonoscopy and they said repeat in 5 years, it was a little bit higher level than the care medical record staff felt comfortable. Then we lost we had a whole brand new medical record staff due to some staffing changes. So right now, I just found out this is on hold. So we're going to do education to make sure the providers know how to go in and update that quality measures tab. So we do feel like that having that process was really good. It took some burden off of the provider, but you really need to have strong medical records. So we had one lady retired. She had been with us for a very long time. She felt very good with the system, and she understood stuff. And so the newer person, and then with all the COVID scanning of COVID consent forms, our medical records are stretched very, very thin. So that may be something that we need to work on, trying another option to help get that stuff in correctly and making sure that the documentation is added to that quality form. If you'll advance to the next slide. So you can just see, we also make sure that the staff, not only the medical records, but the providers, that they know how to use this form, and that date has to be in one of these boxes, and that they're dropping the F code from that form so that it will go in the system to be billed. Okay, next code. Next, sorry. But you can kind of see this was from last year. So we ended up in October before we started this, we were at 35%, and year to date so far we're at 39%. So we felt like that's the most movement we've had at one time. And I think we did a few years ago, we did a huge push with using the FIT test. And what we found is the FIT test is great if the patient is not able to get off work, or they're not able to afford, they don't, uninsured and can't get in, or just say, I absolutely not. But it's a lot of work. You've got to print labels, you've got to mail it, and even when the patients, if they dig in their stool, some people would not want to do that. So what we found is, if they didn't write the date and time of the specimen, when those tests were mailed in from the patient's home to Quest, we had a huge amount of turnaround. So we really try to stress, try to work smarter, not harder, and try to be really push and encourage that colonoscopy for that, because we feel like it's a 10-year thing. The patient doesn't have to worry about it quite as much. So that, and then the Cologuard is 3 years. So we're hoping that as we continue to get the patients on that 10-year mark, that we'll continue to see the climb. Next slide. So we also are trying to look at, like, from a population health and from different payers. So how does it affect, when we do things, we've always done a big picture and big campaigns, but now we're trying to look at the individual payers and making sure. So we did add ORB. And one of the things we wanted to see is, how is that population? We just have started that. So you can see we ended out in October of 2020, we were at 46.5. And if you'll go to the next slide, you can see where we're at year to date in our Medicare population. So we're at 49. So it stayed about the same with the total population, along with our ACO population. Okay. All right, next slide. So for that Medicare thing, we felt like another way that would be helpful is working the supplemental claims report from the ACO. So we had a clinical systems analyst who they went to, if they worked that report from the ACO, and they went in, if it was not in the system, they would send the records to a request for records, or they checked the North Carolina Health Information, the HIE, to see if they could pull that report in. If it was in the system, they ensured that the other health reminders were satisfied, and if not, they would go ahead, the request of records, when it came in, hopefully it would come back in. We were very good at doing it for the first last few months of the year, but then we, as we have surges, we've had a couple of floods and acts of God, so we've not been able to do that. So we're trying to get back on that. It's better if you do it monthly. We did it at the end of last year, and so since it was all the claims throughout the year, it took a very long time. But if you work that report monthly, it may be 50 or 60. It's not quite as overwhelming. The HIE is very new for our state and our staff, so we did have to do a lot of training to make sure that they felt good about going in and pulling those records and how to get those scanned to medical records, or so that they can add them to the patient's charts. Next slide. We also look at the results by provider by month. So if you can see here, this just is right out of PA. So you can see that we try to focus on the bottom performers. So like right now, we've got everybody that's less than 40%. What we want to do is maybe have our clinical systems analysts be able to reach out to the staff to provide re-education or do a site visit to evaluate the workflow and monitor monthly the next month. So if this is Dr. John Doe, if we train him and his nursing staff this month, check back to see if we see any gains. This measure has a longer lag, because if you do a referral for colonoscopy, right now what we're seeing is that many of the practices are booked out, or with COVID, the patient might get COVID and have to schedule. I know for my son, he actually had needed his wisdom tooth pulled, and it took between the doctor's office having to reschedule or him twice he had to reschedule. He was exposed in quarantine. So what we're seeing, one referral may require our referral staff 2 to 3 times to rebook and reschedule that patient. But so we just want to make sure if we do train a provider and their staff, if we teach them something, we want to make sure is it taught and caught. Taught, not caught is what we talk about a lot of times. And sometimes you can teach something, like we do big twice-a-year trainings, but sometimes people just don't get it. And there's so many different things, and we've had a lot of turnover, a lot of people out sick, and a lot of visits in the car. So it's hard to prioritize and make everything work. So we also wanted to make sure that when we do have new hires, that they get a very strong base understanding of not only how to use the current EHR we have, but how each quality measures, how to document it. So sometimes what we're trying to do now is start a monthly, offer a session called 101, EHR 101 or Quality Measures 101. So we've had 2 sessions now, and so that allows the nurses can log on at lunchtime, the newer staff, and they can review any questions and ask. So we may cover a topic on it. So next slide. So we break it down and try to make sure that each person knows what their role is. What is the nurse's responsibility? So this is a slide that we did, and one thing that we found that a lot of times the staff, if the patient refused, if they accidentally changed it to never remind me again because the patient said no, that messed up that reminder forever. So what we try to do is if the patient refuses, make sure that they know to keep reminding it every time the patient comes in, so the patient may, if they hear it frequently, hopefully they'll agree to do it. And so making sure the staff know how to do each one. You'll go to the next slide. And this is just something we gave to the staff, just so that they can understand the choices. Some of the MAs may not have been very familiar with that, or even some nurses, if they had worked in a different setting, they never heard what a Cologuard or a fit test was. So we kind of explained, have like this little cheat sheet, how to do that, and that's in the quality notebook at every location. Okay, next slide. Next slide, please.
I think that might be the last slide.
Okay, sorry, I had added one more before. We just talked about our next step. So for the rest of this year, so since we're going down, we have not very long, time is flying. We just want to do another push, and we're going to try to do our other populations. Our plans is to work with their OB. We have contracted OB staff, so we plan to do a training for them. A lot of times they see women and it's a missed opportunity, so we're going to do a training with them, our Ryan White provider as well, and then work with we have a new managed care department that's working with Medicaid. So we had a training yesterday afternoon on colorectal cancer screening and how to talk to them and make sure that they understood how to offer it and understood that they could work off that same standing order. So that's it for now. And any questions about anything?
That was fantastic. Thank you so much, Allison, for sharing that information. I'm actually going to look at the chat, and I'm also going to ask if we can unmute the lines as well, if anyone would like to ask a question verbally.
I'm sorry, Steph. I muted everyone and then I unmuted everyone. I apologize for that. I am rusty. You did get a message in the chat from Susan Fisher asking to please add the additional slide.
Sure thing. We can absolutely do that. As well, I do see a question in the chat from Caitlin Haggerty, and she's asking, what services are you utilizing with ORB?
So we just have started with the CCM services for our Medicare patients only, and then we are also doing transition of care for Medicare. So it's I think it's any new process, there's bumps and bruises and learning it, but we've been pleased that Orb has been very responsive. So we're still, I think we went live in April. So when we had some interface issues, so it's been a little bit from the manual, but we're starting to see the revenue come in. I know my mom is actually a Medicare patient, and so she actually loves the services. So she said, I'm a nurse, so she says, I've got a nurse I can call anytime I want. I'm like, I know you do. But she was talking about the other lady. So she's very pleased. They've been very good. And if we have had any patient complaints or provider complaints, they've addressed it with their staff very, very quickly. So we're glad we made that decision.
Fantastic. Thank you so much for sharing. In terms of the workflow that you were sharing earlier, where you had the health record staff do that process of dropping the F code and putting that information in, what were some lessons learned trying to engage the clinical staff, like providers, to be okay with that process and being comfortable with it? Could you share a little bit about that?
So for that process requires the provider 31 clicks. So my Dr. Darlene Presley, she is the quality champion provider that's leading it up. So we have a ticket in for systems optimization, but this process for this measure is so it was based out of a provider request. We tried putting it under, anyway, we really wanted the doctor to do that F code. We had a few providers that complained originally because they're like, where are these open notes coming? But once they realized that it helped improve their measure, they were okay with saving and signing with the task. So
that's
we felt
fantastic.
like they saw it as one thing the provider didn't have to do, because if they didn't do it, or it's one thing they know the provider's nursing staff, their time is valuable as well. The nurses are making the phone calls back to the patients, dealing with all the forms. So to have that taken off of their hands, it's one less person to do, and it's minus 31 clicks that somebody else is doing. So I really hate that the medical records are not able to do it right now. So we'll have to try to find somebody else to work that, or make sure the providers know what to do.
Well, that's fantastic insight. Thank you for sharing that. There are some other questions in the chat. So the first one is in relation to the EMR that you use, which is Energy EHR. And then the second part of their question is, are your health information management record staff members, are they coders?
No, we have a separate coding team. So if you look at what that F code, can you go back to the slide that has the F code on it? Right here. Go back right. So that F code, if you'll go to the next slide with the screenshots, you can actually see what that code actually says. The only thing it says is colorectal cancer screening documented and reviewed. So the provider has the task. So we're running reports. So when I looked at it, because it's just, they have to look at it. So they have to sign off their tasks. We run a task report, and if they are not signing off on their labs or their referral results, that goes all the way to the quality. So they have 48 hours to do that. So I know they've looked at it. They know they've looked at it. It's on the encounter form in the provider's name, and they've had to sign it. So we felt really good, like from a ethical legal standpoint, that really that F code is just saying that they've looked at it. So that provider is agreeing and understands that when they sign that encounter, that's what that code means. Does that make sense?
Yes, it does. Thank you so much for sharing that. I'm going to see if there's any other questions that might come through. I'll be checking the chat, but if anyone would like to unmute their line to also ask a verbal question, I'll give just a few minutes or so for folks to do that as well. Okay, hearing no verbal questions, and I do not see any other further questions within the chat. I just want to take a moment to thank you again, Allison, for taking the time to do this presentation and highlighting the impact of that patient engagement campaign and recuperating from some of the time lost from COVID. So that was fantastic. Thank you so much for sharing this.
Thank you.
Great. So I'm going to go ahead and proceed with the agenda for today's session. And I'm actually going to pass the floor to my colleague, Fred Ira, who's going to walk us through the next two agenda items. And this one is in reference to a look ahead for PCMH 2022. So Fred, the floor is yours.
Thank you, Stephanie, and good afternoon, everyone. My name is Fred Ira, and I've been asked to speak to the QTECH committee with regards to PCMH 2022 and a look ahead. Next slide. So I am the transformation coach at HCN as part of the clinical quality team. And one of the hats that I wear in that role is also being a PCMH CCE and being one of the consultants at HCN to help our health centers either obtain or maintain their NCQA PCMH recognition. Now, about 3 years ago, NCQA changed their 3-year bulky renewal policy to an annual renewal, where every year we're going to be submitting an abbreviated version of that big application that we used to do, that many of you probably remember, or maybe you don't remember because you blocked out those memories. So every year we have to submit certain data and certain things that we're asked to check in. So in the last 3 years, that hasn't changed much. They change from year to year very slightly, ever so slightly, but they just released the 2022 version of the annual renewal. And this is why I was asked to speak today, because some of the things that they're going to be looking at and we're going to be asked to report on have changed. So I just wanted to bring it to everybody's attention so that we're all aware of what we're going to be submitting next year. I know we've kind of gotten into the groove of kind of submitting kind of the same information for the last couple of years, but it has changed pretty much almost everything except I think for one of the concepts. So I'm going to review some of the things that have changed here just to bring it to everybody's attention, whether you participate with Health Choice Network PCMH program or you do it on your own. It's a good thing to be aware what we're going to be asked to report on. Okay, so I'll go ahead and go into that, and thank you. So for the 2020 NCQA Patient-Centered Medical Home annual requirements, I summarized them here. So, you know, there's 6 concepts inside of the NCQA PCMH standards and criteria. So, you know, under team-based care, there's like, I think 10 criteria. They really only ask you to check in on one of them, okay? It does happen to be a core measure. It is something that we didn't actually report on before. I'll go into a little bit more detail here in a minute. For knowing and managing your patient, there's about 20 of them, 26 of those criteria. They're only asking us to provide data for 2 of those. For patient-centered access, there's actually 12 of those criteria. They're actually asking us to report on 2 of those. And as you can see, all of these are core measures. They're things that we're expected to be doing as a patient-centered medical home. Go ahead, next slide. For the care management and care support, there's 7 criteria on that one. They're only asking us to report on 1 of them. For the care coordination, there's, I believe, 17 of those criteria. They're actually asking us to report on 3 of those. I know there's 4 listed here, but we have the option to do one or the other. 2 of them we have to do, and then we have an option to report on one of the last 2. And for the measuring and performance measurement and quality improvement, the QI concept, there's 16 of those criteria. They're only asking us to report on 3 of those. Okay, next slide. So to look at it a little bit deeper, just so we know, so everybody knows and everybody's abreast, for the team-based care measure, they're asking us, before they used to ask us on what our process was on structured communication, which was, are you guys doing huddles and this and that, or you have a dashboard in the EHR, et cetera, et cetera. They're not asking us that anymore. They're asking us to attest on staff involvement and quality improvement. This is on your monthly PI meetings, your quarterly performance improvement meetings, your quality improvement meetings, whatever you guys call them, how often they're being done, and are they involving your staff? So they want to know the frequency of those, and they want you to report on that. Next slide. That one you only have to really attest to. You don't have to really support any data. For the next concept, knowing and managing your patient, they're asking here for the first one for medication lists. They want to make sure that you're maintaining an up-to-date list of medications for more than 80% of your patients. So they're going to ask for numerator and denominator data for a specific reporting period. They don't define the reporting period. That's up to you. You can look at a month, a quarter, half the year, a year, etc. But you have to submit that data. It has to be site specific. So if you're renewing one site, 5 sites, 10 sites, however many sites your organization has, you have to submit the supporting data for each one, and obviously it would have to be over the 80%. If we're unable to generate, depending on what EHR you're on, if you're unable to generate an automated report to show that, then there is a way to still meet this measure. You have to do a chart audit of 30 charts. So you would have to pick 30 and then do a chart audit and then supply the data that says, yes, we're maintaining an up-to-date list of medications for more than 80% of the patients that we chose on our chart audit. So we're going to have to submit that data. The next one for this concept is based on clinical decision support. This is an attestation. They want to know how many of these particular ones we have clinical decision support following evidence-based guidelines for the care and conditions across at least 4 categories. And then you basically just pick the ones that you have evidence-based guidelines for. Okay. Next one. Next slide. For patient-centered access and continuity, this is also a new thing that we haven't been reporting on, at least not in the annual report. All of these are part of the transformation process when you're doing the bulky application. But for the annual report, we haven't been submitting this data, but we're going to have to now. So timely clinical advice by telephone. They want a report, and they want to see numerator, denominator data. The numerator is going to consist of clinical advice calls that were returned within the expected time frame, because as in your policy should state that you answer clinical advice both during and after office hours. It has to be within a certain time limit, within 24 hours, within 8 hours, however you guys define it. They want to know, A, are you meeting your own expectations? That would be your numerator. And the denominator would be the total number of clinical advice calls during and after business hours for a defined period of time. So if you're looking at a month, you got 10 calls, 5 during business hours, 5 during after hours. That would be 10 in the numerator, or the denominator, excuse me. And the numerator would consist of how many were answered within your defined period of time. Okay. And they do put a note, which we all know as well, that clinical advice does not take into consideration calls that were made for prescription refills or appointments. Those do not count as clinical advice. So we have to omit those. And they want at least 7 consecutive days of data in submitting this report. Okay. The next criteria that we're going to be reporting on for the annual reporting is PCP visits. It's patient visits with the clinician team. We all know as part of PCMH, the patients have the right to select their own care team and primary care physician, and they want to know how many times the patient came in versus how many times they came in and actually saw their selected primary care physician. So we have to submit that data, site specific, for a specific reporting period of time. Next slide. Care management. So before, we used to just have to submit the guidelines that we were picking for patients who would benefit from care management, as well as a report on the number of patients who fell into that category using the defined criteria. We don't have to do that this year. What we do have to report is the number of patients from the denominator with a complete care plan. Denominator would be the number of patients who would benefit from care management. So we still have to kind of do the reporting portion, but then we have the numerator would be how many of those patients that we identify have a completed care plan. And obviously that is site specific as well, and is for a defined reporting period as well. Next slide. The next concept is the care coordination. This one actually stayed the same. This is the only one that didn't really change. The two required ones are questions on regards to lab imaging about flagging abnormal and normal labs and images, what the process is there. This question has been the same, and we actually receive auto credit for this being, or those centers that are on Greenway. So this hasn't changed. Next slide. Those two are the mandatory ones. And then the ones where you have the option, you can either report on lab and imaging test tracking or referral tracking. So either one, you pick one of the two, you don't have to do both, and you submit data on that. For the lab and image test tracking, that's the denominator is your number of lab orders or your number of imaging orders for the imaging one. And then the numerator would be the number of labs ordered for which the practice received a lab order result report. And then for the referral tracking, it's basically the closing the referral loop. How many denominator, how many referrals were sent out, and the numerator is how many did we actually receive a report back from the referral. So those obviously are site specific, and those are what we have to report on for care coordination and care transitions. Next slide. The last concept, and the last one that we're going to report on, are the clinical quality measures. And this is the QI worksheet that we have to do every year. It's kind of the same, but it's a little bit different. And they've tweaked it a little bit. Before, we only had to pick 3 clinical quality measures to report on. For next year, we're going to have to do 5 clinical quality measures across 4 categories. And they're either in immunization, in preventative care, chronic or acute care, and or behavioral health. So we have to pick 5 measures across those 4 categories and do the whole, like a PDSA cycle. We have to define the numerator, define the reporting period, and then they've omitted the action items, so we don't have to submit action items, but they want us to pick and then submit some data with regards to the clinical quality measures. Next slide. All right. The second part of performance measured and quality improvement is the resource stewardship measure. These are either measures related to care coordination, that's advanced care planning, care coordination, or measures affecting healthcare costs, which could be your brand versus generic, or stuff like unnecessary imaging, etc. And then it's the same. They want you to pick at least one measure of each type. So we're going to have to pick one of each. We're going to have to report on it, and we're going to have to submit some data and reporting on those 2 measures. Next slide. The last part of the QI and part of the worksheet is the patient experience. This is your patient satisfaction survey. They want you to monitor at least one measure from your patient experience, which is relating to one of the following categories, which we know should be part of your survey, either access, communication, coordination, or self-person care. And then they want you to submit data with regards to something from your survey in regards to performance measurement and quality improvement. And that is what we can expect to see for the 2022 annual renewal. I know it's a little bit different. I just wanted to make everybody aware of what we're going to be reporting. It is a little bit different. For those of you who work with me and work with the clinical quality team with that, we will obviously help you and obviously game plan with you and get you ready to submit that. For those who don't do it with us or whatever, I'm just making you aware of everything. I did include as part of the materials for today, the document from NCQA, the release as well, which has all of the information with a lot more detail than I just provided for you. This is just a summary, but I did include that in the meeting materials, so you will be able to download that, or you could go to the website itself, to ncqa.org, and download all that. There is a updated version 7 of the criteria that we are using, which is the 2017 NCQA PCMH criteria. They did release version 7. You can download that from the website, or if you want, you could always email the HCN Clinical Quality Team, and we can forward you a version, that version as well. Any questions?
Thank you, Fred, so much for your presentation on what to expect in PCMH 2022. We do have a question in the chat related to folks who may be moving in their EMR system. So we'll take a look at that question and get back to you. They're basically asking if there's anything to prepare prior to that EMR change that they should be informed on.
So as it is right now, I am going to be receiving training as well in the new EMR. So I will become abreast and I will become an expert. I've heard wonderful things about the reporting tools in the EMR. So I am expecting all of these things to be solved or to be resolved and to be available to us. If not, like I said, like I mentioned before, there are other ways to meet if we're unable to generate an automatic report. There are other ways, workarounds that we can do in order to meet the reporting aspects of what we need to submit. Thank you.
Awesome. Fantastic. We'll be in touch as well. We do have another question here. So when you say 2022, are you, there's a health center stating that they're going to submit a renewal in December. So will that be considered under the 2022 requirements?
Yes, if you have to submit before December 31st, then you can still use this year's 2021's annual reporting requirements. If your date falls into your actual submit date, not your expiration date, because the submit date is 30 days prior to your expiration date. If your submit date falls in 2021, so before December 31st, 2021, you can use the 2021, well, you're expected to use the 2021 criteria. Once you get into that January 1st, 2022, then you have to use this. So yes, good question. And I think I know who asked that question.
Fantastic. I'm looking again at the chat, but I do not see any other questions.
Excellent.
Fantastic. So I think with no other questions, we could proceed to the next agenda item. And you'll be
Hey, it's me
taking the
again.
floor from here. Yeah.
All right. So it's me again, and I'm going to speak to you a little bit about the 2028 HRSA National UDS and some of our UDS data numbers. Okay, next slide. So as we all know, 2 weeks ago, I think it was, HRSA released all of the data for the 2020 UDS data was released on all community health centers across the country. So what we did is we kind of looked at a couple of different ways to look at the data, and I just wanted to share it with everybody. And a lot of this data we will be including in the meeting materials. We're going to also include some links so you guys can go in if you haven't already and look at your data, see how you compare to everybody else. We've kind of aggregated the data, at least for HCN, to see where we stand versus the national average. They released all the new national averages, and also where we stand against ourselves. And what we did here too also, and this is the discussion that we've been having with Dr. Long as well, is we're looking at the rolling 12 months as well, because we know, at least the clinicians know, when they look at the UDS measures versus the rolling 12, sometimes they don't match up because we're only looking at, you know, the year to date. We should be looking also at the rolling 12. So we're also trying to incorporate that data as well. And you'll see in some instances, the rolling 12 numbers are a little bit higher, sometimes they're a little bit lower. But what I did want to point out here, and where we can kind of look at and be happy, is on a lot of these measures. For example, we'll look at the first one. We are exceeding the UDS 2020 HRSA national average. So as you see here, year to date through July 31st of 2021, HCN overall, everybody that is, you know, as part of the Health Choice Network, that we have your data, we've put it into here, and we are higher than the national average. We are at 44% right now through July 2021 for the childhood immunization status. And as you see, the national average is 40.42%. So we are exceeding the national average. Same can be said for cervical cancer. The UDS national average is 51% for cervical cancer screening. We all know everybody took a hit on that measure, especially with COVID and everything, but we are at 53.9%, again, above the national average. So fantastic work there. Breast cancer screening, it's a new UDS measure. It's not a new measure, but it's new to UDS reporting. And we are, again, above the national average as an HCN. As HCN, we're at 47.7%. The national average is 45.34% there. For the weight assessment for children and adolescents, the national average is 65.13%. Again, this is one of those measures that took a hit with a lot of the telehealth visits, the patients not coming in, et cetera, et cetera. But we are, again, exceeding the national average through July 2021. For adults, we're actually killing it on this one because the national average is 65.72. Our year-to-date number is 85.1, so fantastic there. For tobacco use, this is one of the ones where we're not exceeding the national average. The national average here is 83.43%, and the HCN average through July is 70.2%. Next slide. All right, for statin, once again, national average is 71.92. HCN year-to-date through July is 76.6, so fantastic work there. For IVD, use of aspirin and another antiplatelets, we're actually a little bit below the national average. This national average is 78.8, and we're actually just below that at 76.5. Colorectal cancer screening, which took a big dip for everybody across the board. National average is 40.09, we're at 40.5, so we're basically at the national average or just slightly above it. HIV linkage to care, we're right there. The national average is 81.41 and we're at 78.8. So we're basically at that. For HIV screening, we're doing fantastic there. The national average is 32.29 and year to date for HIV screening, HCN is at 51.6. So fantastic job there. For screening for depression and follow-up plan, now this one was one of those tough ones, especially last year when we had the glitch with Greenway and the reporting, the way it was reported. So we had a lot of ground to make up there, but we did pretty good because the national average is 64.21, and year to date through July for screening, for depression screening, we're at 69.7. So good job there. Next slide. Dental sealants for children, again, we are above the national average here. 48.68 was the national average, and HCN's at 67%. Depression remission. Now, this one is a difficult one. This is a very difficult measure. This is new to UDS reporting, and we've gotten a lot of questions on how to improve on this measure and everything. And one of the things I can say is the national average on this is 13.69. We currently are at 6.3 as a network, as an average for that. Now, I will say that, there are some problems with the reporting. We are expecting some fixes to be coming, and also we'll work with that, and we'll also be working on helping you with workflows on how to improve that, and we do have some recommendations for that, so look forward to those discussions as well. For diabetes, this is a negative measure, so this one you actually want to be as low as possible. The national average is 35.6, and we're actually below that, which is good on this one for diabetes, and we're at 34.3. For hypertension control, the national average is 57.98, and we're actually at 62.9. So again, we are above the national average for hypertension control. Low birth weight, that again is a negative measure, so we want to be as low as possible on that. National average is 8.18, and we're just above the national average, which means we're not meeting the national average of 9.2. And access to prenatal care, once again on that one's not a negative measure, that one's a regular measure, but we are below the national average of 73.48, and that is where HCN is at 66.3%. Next slide. So this is kind of an aggregate of all of that stuff that we kind of broke down for you if you wanted to see it all in one. This is an aggregate of the UDS year-to-date July 2020 versus the rolling 12. And we also included the national averages as well, if you wanted to see it all in one. Next slide. So this slide has the link to all of the data where you can go in and you can actually pull up by state. You can look at your individual health center. You can see how you compare. It has all the data. It has the national averages. It has everything, all the data from UDS, from all health centers. So we included this slide that has the link with all of your data. If you haven't already looked at it, go ahead and look at it. We also included some data that we've aggregated as well as part of the meeting materials. Next slide. One of the things that we are working on as the clinical quality team is we are working on revising and making clinical workflow documents for all of these measures. We did have some existing ones and we are revising them, making them up to date because we know they change pretty much every year. And what we're doing is we're making two versions. We're making a comprehensive version which has a lot more information, what the report is looking at, et cetera, a lot more detail. And then we're also having a provider version. Dr. Long has challenged us to make this as short as possible, no more than 3 pages. So this basically just tells you where to go, where to click in the EMR in order to meet this measure, what you need to make sure that you're doing in order to do it. So each measure is going to have 2 versions, the comprehensive and the provider version. And we are going to be rolling all of the, you guys have seen already, some of these have already come out. They've already been published. So hopefully you have seen them, you have shared them with your teams, but we've also included here the link as well. And we are constantly adding to that. So we'll be hopefully have all of them done sooner rather than later. Next slide. I've also included the famous UDS spreadsheet. This has all of 2021 data as well as whatever you guys reported for 2020. This has all of the data through July of 2021. I'm not going to go over this. We already went through this, but this is included. This will be included in the slide. So if you guys want to go ahead and look through and see where you stand, see where you compare with all the other HCN health centers, by all means, go through this, look at this, use it. And that's it. That's all I have.
That's fantastic. Thank you so much, Fred, for showing this data and presenting it to the committee. So we do have a few questions in the chat, one of which is actually in reference to the goals for the measures and the national averages. So within the handout section of today's meeting, we did provide 2 separate Excel documents for everyone to download, one of which is the 2016 to 2020 UDS CQM compliance, which has the information that's accessible within the website, the HRSA website, with the publicly published HRSA UDS data. We also have the UDS compliance report July 2021, which is very similar to what you're seeing on the screen now, that also provides some goals for each of these different measures. So that is accessible to everyone in the meeting today. We do have another question here in reference to, do we know when awards will be announced? I believe they were discussing that awards may be discontinued. So I believe that this is in reference to the HRSA Quality Improvement Awards, the QIAs. So Fred, do you want to kick off with that question and we can
Sure,
add in?
yes. So I think it was, I don't remember exactly when they announced it, but HRSA had announced that there will be no QIAs for 2020. So they did make that announcement, and we did see that when they released all of the data. Now I'm not exactly sure what the plan is for 2021, if that's going to change. We are expecting to get updated and everything as soon as we do have more information. Obviously, we will provide it for everybody, but we will, of course, be helping everybody to try and improve all of their UDS clinical quality measures by, having these discussions, by reviewing the data, by providing the workflows and everything else, those clinical workflow documents that we are working on. So yes, we are going to be helping everybody improve those. And if HRSA decides that they want to go back to the QIAs or how they're going to reward our health centers for doing excellent quality work, we will keep everybody posted on that.
Fantastic. Thank you for sharing that, Fred. And then we can also provide in our follow-up email the the specific presentation from the Today with McRae that provided some more insight on that as well, so that you all can have that within your records. Okay, I'm checking the chat again just to see if we have any other questions. I am not seeing any other questions at this time. So Fred, thank you so much for taking the time to present the data to our committee and walking through a lot of the strides that have been able to been accomplished now in 2021 to make up for COVID. So that's fantastic. Thank you for sharing.
Thank you. And I just want to highlight all the work that all of our health centers have done. As you can see in the data that I just provided, that all of the health centers that we work with the Health Choice Networks, as you can see on most of them, we were above the national average. So great job to everybody. I just want to say thank you.
Fantastic. So with that being said, we're going to go ahead and wrap up for today's QTECH committee meeting. We do have a few action items we want to bring to your attention in terms of next steps for this group. So on this slide, what we're actually looking at is an opportunity to also submit your health center spotlight. We're always trying to find opportunities to highlight the amazing work your teams are doing on a daily basis for quality measures or any sort of operational workflows or items that you want to share to the group. So we want to open up the opportunity to you all. So we just ask that you submit either this form or reach out to the HCN clinical quality team so that we're able to get you in the books and on our agenda to share that amazing information. Other things we wanted to bring to your attention include the upcoming Alliance Chicago and Health Choice Network Virtual Educational Conference opportunity. We do want to just put this out there for you to have an opportunity to register and attend the event. Other upcoming events for you to be aware of is our virtual clinical leaders mentorship office hours that will be taking place next Tuesday, August 31st from 5 to 6 p.m. Eastern. This is really just a chance for clinical leaders, either emerging clinical leaders or seasoned clinical leaders, to come together and ask questions. And it's really an opportunity to hear some guidance or responses from other leaders in that same capacity. So we wanted to make you aware of that. We also wanted to make you aware of the upcoming Clinical Leaders Workshop that's taking place. There are two options available for this opportunity. So there is an in-person option that will be at HCN headquarters, as well as a virtual option. So the Clinical Leaders Workshop is really trying to address the core knowledge and skills needed for clinical leaders, whether you are, again, are emerging clinical leader or a seasoned clinical leader. There's definitely something for everyone involved. So this link is here for you to register for that. There is an upcoming webinar related to social determinants of health. It's a part 2 of a panel discussion around data collection for social determinants of health as well as workflows. So this link is available to you all to register for the event. And with that being said and no other questions, we just again want to thank you for taking the time out of your busy schedules to attend our QTECH committee meeting and participate in the discussion. We appreciate you and all of your efforts on a daily basis. So thank you and having a wonderful rest of your day.